think there's quite a few people watching now. So to start off, I'd like to say a massive thank you to Dr. Teulieres for giving his time this morning. And thank you to everybody who's registered. I'm sure it will be a really interesting, informative talk. Just a brief introduction. First of all, some just housekeeping. Everybody who's registered, your video should be off and you should be muted. And please respect that so that you don't interrupt Dr. Teulieres while he's talking, because it can be very distracting if people keep putting their videos on and off. This seminar is being recorded, and everybody who's registered will get a copy of that recording. So there's no need to try and write down every word that Dr. Teulieres says. You'll have your own personal recording. So a brief introduction. Dr. Louis Teulieres is a medical doctor who received his degree at the University of Nice in France. He completed specializations in immunology, hematology, immunopathology, bacteriology, and epidemiology at Pasteur Institute in Paris and at the CDC in Atlanta. Dr. Teulieres is an active member of the immunology department and the research team who received the Nobel Prize 2008 for discovering the HIV virus in 1983. In clinical practice, he focuses on treating immune and infectious diseases such as Lyme disease and other tick-borne infections, as well as neurodegenerative conditions. So over to you, and just give me the word and I'll start sharing the screen for you.
Okay, thank you very much for inviting me. I'm very glad because it's the first time I will be talking to a UK-based patient association, and which is strange because we are working with Leicester University, and which is in UK, and so I'm very glad because I think there is a real need of this collaboration between research university centers and patient associations and doctors and colleagues which are willing to know a little bit more. So I'm very glad, and I should thank you on my side too. So can proceed to the conference. Okay. Okay. Thank you very much. So let's start now. So the title of the okay. Thank you very much. So the title of the conference is this phage testing for Lyme disease. As I said, I've been working with Leicester University, and we also have created a charity, a UK-based charity for infection and bacteriophages group. And so although you see my French number here, the telephone number, the charity is based in London. Can we start, please? First slide. So we will talk about the use of phages as a diagnostic tool. Phages have been known already to be used as therapeutic ways for bacterial infections. They have been discovered by Canadian and French scientists, which was working at Pasteur Institute, Mr. Phelix, which was a biologist and a medical doctor, and many of the phages were used widely in Europe after that, in the beginning of the 20th century, and also in Canada, USA, and some of the pupils at the Pasteur Institute get back to their country, and among them there was some Georgian, Polish, Russian scientists, and that settled also the technique there. It was, of course, after that abandoned because what came to people were the antibiotics, and antibiotics were so easy to manufacture, so less expensive to maintain, than the phages, which are living viruses. So you have to have a nutritional media. You have to change the dye after a certain number of reproduction cycles. So it was very hard to manage, and little by little it was abandoned. But it was still kept for some scientific reasons. And while we dealing with Borrelia infections, one of the big question was, is there a chronic stage of Lyme disease? And obviously the tests which were there are not very satisfactory, because I cannot give this answer. PCR, direct PCR, we'll come back later to that, we could try to answer that, but as all we all know that this bacteria does not circulate so much. There is a problem in diagnosing directly through the genetic material of the bacteria. So we were facing a big problem and a controversy about the existence of a chronic stage. And second, this chronic stage, this late stage, created a second problem, which was the use of long-term use of antibiotics, which can be deleterious for some side effects and toxic. And we know, since Eva Sappi in Columbia University demonstrated that the use of long-term use of antibiotics can create this defense form, peculiar defense form of these bacteria, which are the round bodies, the cystic forms. So we were facing this problem, or is there a chronic disease, and how do we treat it? Can I have the second slide, please? So how does that look like? We were trying to, when we first tried to work on the bacteriophage against Lyme disease, we were thinking about having a therapeutic tool. And I remember having seen the last collection of bacteriophage in Pasteur Institute, and it was destroyed in 1993, which is not very long ago, but still, when we were trying to find this kind of solution for Lyme disease, we couldn't have any phages or try to work on a phage in France. And I've asked all these countries, Georgia, Poland, Belarus, they didn't have any bacteriophage directly dedicated to Borrelia. So our first step was to try to find them. And we were, and we knew how these phage are. They are viruses with a long tail. Can we go for the next slide, please? Yes, and this is a video. Yes, can you tell it? It will show you how it works. So you see a bacteriophage. This is a T4 virus. It goes and with some receptors will land on the surface of the bacteria. And then after a while, they will, their tail will grasp and they will inject their genetic material inside the bacteria. You will see that here in the animation. They will inject through the tail and the attachment, they will inject that. So the DNA or the RNA of the phage goes inside the bacteria, and after a while, there are copies, dozens of copies of this phage that will make bacteria explode through the number and through the different several enzymes and proteins. Next slide, please. So what are they? They are. Can you add the image? The phage are specific viruses inserting their genetic material in their hosts, and then can either produce numerous copies that further destroy the bacteria, or, which is very important, can you add please if you click another time, maybe the scheme will come. Yes, that's it, exactly. So I'll show you there. So the first thing we've seen, the landing on the bacteria, the multiplication, and then the lytic activity, liberating in the circulation the phages looking for new hosts. And there is another cycle which is called the lysogenic cycle, where the genetic material is inserted in the bacteria of the virus, is inserted in the bacterial genetic material, and it stays in a dormant stage, and it goes along the different generations, and for some reasons, environmental reasons, maybe antibiotic pressure, maybe stress, they get out of this dormant way of life, they wake up, and they begin to be have a lytic activity similar to this first cycle I described. So we have when we tried first to work on these phages, we started first to work on a therapeutic tool. But when we went to European Union and to the different authorities, even in England or in France, we were facing some very difficult questions. The idea of injecting any viruses to cure a bacterial disease would be difficult to be accepted, and we would be considered as a drug, and we would have to pass all the hurdles, preclinical phase 1, then clinical phase 1, 2, and 3 studies, with a lot of difficulties and budget constraints. And it was very, very hard to envisage. And we were a little bit disappointed when suddenly we thought, but if there are phages of the bacteria, it means that they are either on a lytic activity or on a lysogenic activity. What is the end point of that? Is that there are bacteria. The viruses cannot live by themselves without having a host, even if it's to destroy it or to live with it. So if there are phages, there should be a bacteria. It must be a bacteria. So we decided to switch it was 5 years ago, to switch our research objective, target, and to go for a test. And we developed a specific Borrelia and also a relapsing fever and Miyamoto phage PCR tests. And we have validated first in patients, and first against collection strains, but then in patients, which is most important. Can I have the next slide, please? So, what are you? If we to show you how we did it, we cultured bacteria, Borrelia on plate, and we tested the phage that we had first harvested in the wild, and after and infected the culture, and we can see where there's a specific phage, there is a specific lytic activity. So we can prove that the phage is typed, is adapted, is dedicated to that specific bacteria. Can I have the next slide, please? So after that, we were able to amplify this use. The phages with the target cells, and then we use a virucids to kill this phage, and try to kill them with helper cells and counter plaques. And this is a principle which is used to use some phage tests which were being tried in Mycobacterium. So this technique of using phage as an indirect way to prove the existing of living bacteria has been already done a couple of years ago in 2014 for Mycobacterium. So what we did is, next slide please, to adapt this concept. Next time please. Next one was anthrax, also it has been done. And so we were able to engineer these phage tests and genes in order to have sequences and to have primers that could help us to make the tool. Next slide, please. Next slide, please. Okay, so you see that it has been already utilized from different diagnostics. We developed the test specifically for Borrelia, and we were fortunate enough to be accepted in a very good publication, which is Frontiers. And this year, it was in March 2021. The test was validated and calibrated in 2018. Then we had our patent in 2019, at the end of 19. And then afterwards, we had to confirm it by some routine use. And we decided to not to do it in Leicester University, because Leicester University is not dedicated to have patient routine testing. So we selected a private lab that was managing the techniques that we were using. The first technique the lab had to manage, the first technique was the DNA manual extraction of the samples. We have tried different ways of extracting the DNA with magnetic fields and steel round devices, balls, and it seems that the manual hot and alcohol extraction is the best one. And second, we had to have a private lab that could be that was literate and had PCR techniques, and so little, and that could be in a country in Central Europe. So we selected a Belgium lab called Red Labs, which is near Brussels, and which has a good relation with the Brussels University Hospital. And so together, during the year 2019-2020, we performed about 4,000 of these tests, and that permitted to be confident enough to give that publication to Frontiers, and it was accepted. Next slide, please. So this is the title of the work: targeting multi-copy prophage genes in the increased detection of Borrelia burgdorferi sensu lato first. That was the first test which was developed, Next slide, please. Yes, yeah, we have the same one. And for the validation, which was published in this article, we demonstrated that we had a 90% sensitivity and 100% sensitivity specificity when the sensitivity was compared to normal PCR and to ELISA and Western blot serological assays. Next slide, please. So what is the difference between all these tests? The antibody-based tests give a non-direct evidence of the infection. It has a low sensitivity because we all know that in Borrelia, there is no clear correlation between the bacterial load and the level of antibodies. Why? Because these bacteria do not confront themselves with the openly with the immune system. They hide, they cover themselves with biofilms, they put themselves in cystic and cryptic forms, and so there is the normal sequence of IgG and then IgM and then IgG doesn't stand for this kind of disease. It's not only for Borrelia, but all of the intracellular anaerobic bacteria, which have a very peculiar way of existence, that play hide and seek with the immune system. The antibody-based tests have a low sensitivity, and they cannot distinguish active and non-activity and non-active Borrelia presence. The bacterial DNA-based, which is a normal PCR, is a direct evidence of Borrelia presence. But as the bacteria do not circulate, there is a rather low sensitivity. It can be a better sensitivity for example, in a joint fluid or in a spinal fluid, but these circumstances are relatively rare. It cannot distinguish really between live and dead Borrelia because the genetic material can stay a long time without, even if the bacteria is already dead. But it's very specific. It permits to tell the different Borrelia subtypes. There is another popular test, which is the lymphocyte transformation test, or ELISpot, that provides also an indirect evidence. It has a variable sensitivity. Why? Because first, you have to have what we call memory cells, memory lymphocytes, and they do not appear already, immediately. They appear about 45 or 60 days after the infection, and they don't really identify the Borrelia subtypes. And there is the sensitivity is very technique dependent, and also it depends on the state of the immune system. If you have performed this test while giving antibiotics or while giving immune modulators, or having given them very recently, it can change the sensitivity of the test. And also, it's also very technician dependent, because it depends on the way and the length of the putting in presence the lymphocytes of the blood and the antigen provocative agent. So it can be you can have false negative and also false positive. The phage test is a direct evidence of the Borrelia presence. There cannot be any phage without a Borrelia presence. And the sensitivity is higher because this phage circulates. They circulate to find new hosts, because if they don't find them, they won't live. They won't survive. We were also able to have a specific test for relapsing fever and for Miyamoto's subtypes, which is very hard to diagnose for the time present unless you use this test. And it makes also the difference between active and non-active Borrelia presence. So, because if there is a phage, it's because there is a living bacteria. Otherwise, it wouldn't exist. It's impossible. Next slide, please. Yes, I think you should click another. Yes, do all the clicking, please. So it's a manual DNA phenol chloroform extraction, and then quality control for extraction, quality of extracted DNA, and we perform 3 different real-time PCRs for each sample. As you see, you have 3 different probes and primers, one for the Borrelia sensulato, one for Miyamoto, and one for the relapsing fever subgroup. And one thing which is very important too is each time we have a positive result, we confirm it by sequencing. So there is no false positive. And we pay a lot of attention not to outpass 40 amplification cycles. This is very important, even for normal PCR. If you construct a PCR test with more than 40 cycles, you're going to amplify very short sequences. You are able to amplify very short sequences, and it can lead to false positive too. So it has to be very carefully ended, and we insist on this quality and control conditions before giving a result. Slide, please. Sorry. Okay. I hope you can see me. So the results we showed on late stage patients in a study this year in 2,200 samples coming from European country and all USA. And we were in all late stage, and we were very surprised to see that among the positive, which was 66% of them, so late stage Lyme disease samples were sent. 34 of them were negative. That means that there was no relapsing fever, no Miyamoto, and no Borrelia burgdorferi sensulato. Could be another bacteria, Bartonella or Babesia or whatever. But among the positive, 60% positive, among which 64% were Borrelia Miyamoto. And we were very much surprised that, because we all thought that Borrelia Miyamoto was more in Eastern Europe, Asia, and also United States of America. But now we have the proof, and it's the first time with that size of sampling that we could verify that there is a much higher prevalence of Miyamoto in Europe than we thought. And that could explain why a lot of tests are still stay negative, because for the time being, there is no PCR, normal PCR for Miyamoto, and very few for relapsing fever. So that's why we have maybe this very big sensitivity and positivity rate. All these results were verified by sequences, so we are definitively positive cases. And can we proceed, please? We have okay. Now I'm gonna show you a couple of utilization cases. The first case is a male, age 70, was living in Mexico. He has been bitten by ticks in USA in 2015. He had no typical rash, but since 2017, he had a lot of fatigue, loss of sight, fever, and mild muscular pain in legs and strength, and also urinary problems and a brain fog. So he went to Mexico and to United States to do a lot of tests, including bacterial PCR, and all these tests were negative. He had a small dot with IgG, ELISA IgG for Borrelia burgdorferi, but all the other tests were negative. So he was a bit desperate because he couldn't have any treatment, or he tried very few treatments, and he was addressed to us, and we performed the phage PCR tests, and we found that he was positive to Miyamoto, which could explain the fever and the muscular pain and the brain fog. Relapsing fever was negative, and Borrelia was negative. So he was treated with, you can see the treatment here, ceftriaxone, IM and IV, plus doxycycline, plus essential oils, with a pause of 3 weeks, and then changing the cocktail, if I could say so, and with 14 days sequences and cures. That's the way I personally treat these patients, because I'm a bit reluctant of having long-lasting sequences of antibiotics, provided that it could lead to the selection of resistant mutations and bacterial lines of selected mutants, antibiotic resistance, and also that it can create a lot of adverse reaction and side effects and toxicity for the liver and the kidneys. I normally treat the patients on a sequential base, all the sequences separated by poses that permits to clear out, wash out all the toxicity, and also to permit the survivors to gain again and to create a certain bacterial load, and then it's time to strike again, in less of having a kind of bombing carpet of antibiotics that would last for months, 2 or 3 months, that would only lead to a very deep embedded bacteria on the biofilm coverage and in cystic, hiding themselves deep in the tissues and privilege with a higher amount of cystic and cryptic forms. So it was appropriate diagnostic that permitted to treat that patient. A second example, next slide, please, is a male 38 of age, who was bitten in 2016. He has no erythema migrans, and the symptoms were only fatigue, diffuse muscle pain, and a depression. We were fortunate enough to have a Borrelia miyamotoi, which was positive, and he had 2 times 10 days sequence with a quick positive outcome. And as we know it was miyamotoi, we privileged azithromycin and doxycycline, which is, of course, maybe not the gold standard, but it works very nicely on this kind of strains. So this is an example of an appropriate good usage of antibiotics and with the treatment. And we performed another test later, and it was negative. So we could stop the treatment and not to prolong it uselessly. Can I have the third case, please? Is a woman that was lives in Europe, in South Europe. She has no tick bites memories, no migrants. And since 2010, she has a very horrible condition, which is called a stiff man syndrome. These people are completely blocked. All their muscles are completely in a constriction state, and they suffer for a lot of neurological pain. And they have leg strength loss. She was in an armchair. She had no fever, but some chills. And there also, the stiff man syndrome was confirmed, but anti-GAD antibodies positive, although the electromyogram was negative. She had a positive IgG Western blot, ELISA IgG positive and Western blot negative in 2016, and also a Yersinia enterolytica positive in July 2019. So we had a lot of antibiotics. She was also treated with baclofen, and which is a bit similar to disulfiram, and benzodiazepine. And she now is able to stand and have some steps. Stiffness remains, but the arm spasm stopped. And we were able to monitor the treatment and to stop it for a while. And even if the situation is not completely solved, she's in a much better condition than she was when it took the case. Can I have another slide, please? So this is a young girl of the age of 10, which was bitten in 2018. She had an erythema migrans. ELISA and Western blot was positive. She was treated 3 weeks with amoxicillin. And she had no symptoms until August 2019, when she had a flu-like symptom and joint pain. So everybody was frightened and said, well, this is a typical case of relapsing of Lyme disease. And we conducted the evaluation, and all the tests were negative. Even the co-infection tests, and it was only the Epstein-Barr virus which was positive. So she was treated like a normal Epstein-Barr virus without any antibiotic treatment, and she recovered. So you see, the test that can prove the existence or the non-existence of living bacteria can guide you to decide if you have to stop the treatment, start again the treatment, or start for once the treatment, and because there is a proven living presence of bacteria. Next slide, please. This is a male age 8, tick bite in 2008. No erythema migrans. Tick analysis was positive, but he has no symptoms. Phage PCR tests on urine was negative, and we had no treatment. So that leads that even if a tick is tested positive, in some cases, and we all know that, it doesn't infect the patient because maybe it doesn't stay long enough, or the immune system of the patient was strong enough to get rid of it. For whatever the reason, a test that proves the existence or the non-existence of living bacteria can guide you, can guide the patient, can guide the treating and doctors to make their decision tree and to their strategy, and it can help to combat the antibiotic resistance, but non-abusive usage of these antibiotics. Next slide, please. So now the floor is, I can say, open for discussion. Can we have the next slide while we receive the question? So the first question we had is, why is there such a prevalence of miyamotoi? We don't know exactly. It's a fact, and this can be due to different factors. First, perhaps miyamotoi has a higher resistance to antibiotics. There can be also heat and climate factors that permit this bacteria to be prevalent in the wild. And once it is infected, maybe, as we know, bacteria exchange information between themselves through electromagnetic signals, but also through their plasmids. Plasmids are circular or linear formations containing genetic material, and these small entities exist in all the bacteria, and they can exchange information between themselves through this plasmid. It seems that some plasmids are predominant to other ones. So maybe we could think, we're not sure of that the Borrelia miyamotoi plasmid information could be predominant regarding the other ones. And little by little, the miyamotoi strain becomes the prevalent one, the dominant one. Second point of discussion, next slide, please. As I said, it's an evidence of bacterial activity. It's kind of an in vivo amplification system for active infections. And it allows the clinician can evaluate their treatment and discriminate the active or non-active form. We had the first large-scale report on prevalence of miyamotoi, and now we are in a position to continue this work, and we are currently developing a phage-based test for Bartonella and for Rickettsia, and maybe we'll do for other kind of bacteria which are hard to diagnose, and that can lead to and where the monitoring of the treatment is very important. We have had questions regarding, for example, some specific forms of tuberculosis, which are now heavily resistant to all antibiotics, that have been entering in Europe through the vast immigrations and movement of populations, recent movement population in the European countries, and so it becoming to be a need too. So we are now thinking of what will be the next targets. The Bartonella and Rickettsia are almost ready. We are trying to improve them, and hopefully in a few weeks we will be in a position to announce good news regarding these two bacteria. Next slide, please. So, as I said when I started the conference, we have developed that at Leicester University microbiology department, and you should, as a UK-based association, I encourage you to get contact with these people. They're very nice people, and of course, the Patient Association like Lyme Disease UK and Red Laboratories in Belgium, as I said, is the only lab now which is able to perform this technique because they are mastering the manual DNA extractions, they are mastering the PCR techniques, and they have helped us to put that test in a more, let's say, industrial way, and we are hoping to be able to reduce the prices in the future, but we don't know about that because it depends on the technical issues we will be facing. Thank you very much, and now I will be ready for all the questions. Thank you for your help.
Okay, I should be back now. Is that right? You can see me
Yes,
back.
you should. You must be back now.
Back. I was there all along. Thank you. That was, well, just amazing to listen to.
Did the video function went well? Okay.
And I caught on that the screens that were slightly blank, you just had to keep clicking.
Okay, okay.
So that was successful.
Thank you.
Okay, well, we've only got about 12 minutes, and actually a lot of the questions that were submitted, you've actually answered all the way along.
So how do I see them?
I'm going to read them to you. So
Okay.
we haven't got that long to everybody who's watching, but if there's any questions that I can fit in, just pop your question in the chat box and one of the moderators will pick them up, because the ones I've got pre-prepared, you have covered a lot of them. I think the most pressing question for many people in the UK regarding testing of any kind is, could you make a comment on whether this particular type of testing is being validated in a way that the NHS, you know, the UK authorities will accept, because obviously they're very strict about different testing, overseas testing. So lots of people are asking that.
Yes, that's a crucial question, of course. And we are going to have been facing the same question in all the big European countries and whatever, you know. So our intention is to conduct in the coming months a clinical trial in the UK. You know, the same that was used to publish in Frontiers in our paper. Our intention is to conduct one, and certainly we need some help to have a good design of the study that could be accepted by the NHS later without any bias, critic, and whatever it could be, and it should be normally. And so to have a very well designed study, very well monitored, to avoid any discussion and to be able to present it to the authorities. You know, the authorities, they like local studies all the time, you know. We have one which was conducted in France, but with a UK lab. Now we have one in Belgium, but it was a Belgium lab, and hopefully we'll be going for validation in France, Belgium, and UK very soon. But now it's not. It's an experimental test, which have now a very solid routine experience with more than 8,000 tests performed. Okay, so it's not a new test. It is now 1.5 years of existence, and it's about that numbers, that figures. So this is a solid experience, but it is a university and private lab experience for the time being.
So we watch and wait.
No, but as I said, Lyme disease associations are crucial, maybe to help to raise funds or to participate to fundraising or grants, you know, to be included in the grant application. If there is a grant, official grant for this kind of thing, we could involve UK Leicester team could involve a patient association to be a partner to apply for the grant, you know, for example. So we will work on that. That's our target for the coming month.
Okay. So,
but you know, everything was on lockdown in France, in UK, and everything. So
yeah, life's been very difficult.
Yeah.
I say a lot of the questions I can pick bits out that you've actually answered. But one question is, somebody's said they've had another type of testing that was positive on some elements of it. In this case, LTT Melissa test, and they've had some treatment, and they're wondering is would a phage test tell them now after that course of treatment whether the treatment could be continued or discontinued?
Exactly. That's one of the utilization of the tests, is to see if there are some symptoms. Are they due to the continuing presence of bacteria, or the relapsing presence of bacteria, or is it due to some allergic, immunological, histaminic type of reaction, you know, which can be also the case. That was and we must keep in mind that the controversy is exactly that. People, many academic people do not believe in chronic stage of Lyme disease because there is no test to prove it. Our test should prove it. And they say, no, this is not a chronic form. It's only a kind of immunological, inflammatory, long-term reactions. And okay, we said, and you should treat them with anti-inflammatory drugs, immunomodulators, and eventually specific immunoglobulins or things like that. You know, not give the antibiotics. And that's what all the fight and all the aggressivity and all the non-understanding comes from. So yes, the answer is yes. If they wanted to see if their treatment was adapted and really efficient, they could do it. Yeah, of course.
So with the whole argument about testing, you know, about, I mean, obviously the antibody test can't tell us if the infection is active.
Unless you know, in bacterial infection, the rule was you conduct an antibody test, and if it's doubtful, you make a second one 2 months later, and you see if there is an increase in the level of antibody concentration or content. It's what we called, that was an indirect proof of an ongoing process. The plummeting of the antibody level is or was considered as an indirect proof of an ongoing infection, okay, active infection. But it's very tricky because these bacteria do not show and do not confront themselves in an open combat, you know, with the immune system. The TTL test, as I said, is interesting because the memory cells, the problem is that the memory cells don't last too long. So it's limited in time. They don't appear immediately and they don't last too long. It depends on the score. I will not argue with a score of 6, 7, 8 with a TTL. It's certainly something happening there. but with this kind of very doubtful levels, you know, like 2, 3 scores in the TTL, is not so obvious, because it depends, as I said, of the state of the immune system. If there is any treatment, essential oils can modify the response. Anti-inflammatory drugs can modify the response. All immunomodulators, antibiotics. It's not a very stable test, but it's okay. Even if they have been diagnosed, the people have been diagnosed with true TTL, and they have been treated. Maybe it's time to see if there is still a presence of bacteria.
So the actual phage testing will only identify active bacteria, like you said. If it can't, yeah. So
because phages do not last. No, it's like a COVID virus. You know, you spray a virus, it falls on the table. If it doesn't find any host within 5-10 hours, it's dead. You know, it's viruses are like that. They cannot live by their own. No. They have to find a host. And for bacteriophage, it's a specific one. So it cannot be another cell or another bacteria. It cannot go to a salmonella. It cannot go to a staphylococcus. It cannot go to a streptococcus. It has to find another Borrelia. And if it doesn't find it, it dies. Simply as simple as that. In the coming 2 days, it's not there any longer. It cannot be there.
It's absolutely fascinating. Lots of people have asked about the different stages of Borrelia, and there's quite a few questions saying if that goes into biofilm, is the phage affected by that, or can it find any sort of level of Borrelia, you know, round body biofilms?
Oh yes, certainly. The round body, certainly. The question is the biofilm, because we have we take a blood sample, and it's clear that if there is a biofilm, even if the bacteria as expressed is phages, they will not be able to go in the circulation so easily. So we encourage people to take a biofilm breaker at least a week or 2 weeks before.
Yeah.
A kind of an enzyme cocktail with different proteolytic, glycolytic, lipidolytic enzymes. When I say so, I think a cocktail of enzyme is better than only a proteolytic enzyme.
I'm not sure if it's me or Dr. Teulieres who's dropped out, so we'll just give it a minute because we're coming up to the hour.
Oh, so maybe it would be better to have a kind of a cocktail.
Okay, yeah, you just dropped out for a minute. I thought it was me, but it was actually you. But it's fine. You came back in a few seconds. Okay, well we're up. We've had our hour, and it's been really interesting. As I say, many of the questions that were sent to us, you've covered. A lot of them were about co-infections, whether in the future phages would be for co-infections, the active, non-active, the acute, the chronic. You've actually answered them all. So as I said before, go on.
You can send them to me and I will be happy to make a written answer if you need.
Yeah, I was just going to say, if we have any outstanding questions, I'll go through them again and cover, see exactly what you covered. And if there's any outstanding ones, if you don't mind, I'll ping them over to you. That'd be brilliant.
They're mostly happy because we really need a good connection with patient association, as I said.
Brilliant. That's absolutely brilliant. Well, again, thank you for giving us our time. We really appreciate it. People in the UK really appreciate, people like yourself giving their time. So just a massive thank you to you. Thank you to everybody who's registered and watched today. You will all be receiving a recording, and just amazing. Thank you very much, and
Bye.
bye.